So it's Friday, so it's time for Poets. Some of us know that as Push Off Early, tomorrow's Saturday, but in this context it's the Perioperative Enhancement Team. Inspired by Dr. Sol Aronson and the team at Duke, a selection of clips to get us thinking about the next steps in providing world-class perioperative care. You'll find the full lectures in our back catalogue, or join us at the upcoming Perioperative Practicum for expert discussions, business case tips, and hands-on workshops. Go to www.ebpom.org and look for our international programme of perioperative practicums. Top Bed Talk. So I'm joined once again by Mike Grocott. Mike, how are you going?
Very good, thank you.
Excellent. We've got two guests here. Laurie Heller, who's a cardiac anaesthesiologist from US Anaesthesia Partners in the Swedish Medical Center, which is in Seattle. And Mike Scott, who's professor in the Department of Anesthesiology in the Virginia Commonwealth University Health System in Richmond, USA.
Good afternoon.
Laurie, hi.
Hello.
So, Laurie, you led us in a fantastic session earlier on today about the challenges of anaemia in the perioperative setting. You went through anaemia generally, but very much in this focus thing. And at the beginning of this, you showed us a lot of data about the association between anaemia and poor outcomes.
Yes.
Can you tell us a little bit more about that?
So I think the data is very overwhelming. Any population you look at, when patients come in anemic, they just do worse. And it's not just in that immediate postoperative, perioperative setting, but 5 years later, 8 years later, if they come and present to us anemic and have their elective surgery, then they don't do as well.
And is that just an issue later in life, or is anaemia still... Well, like when I was a kid growing up in London, when my parents were post-war in London, we talked a lot about anaemia. We got checked to be... And lots of kids around were badged as anemic. You know, they'd be on iron supplementation, they were supplementing the food. Whereas in more recent years, I don't hear youngsters talking about it. Has it slipped off the radar in some way?
You know, that's an interesting question. I think it has a lot. I know in pediatric populations it's uncommon that they're going to draw your blood for anemia unless you have some sort of risk factor for it. So if there's a blood loss or trauma or surgery, but in general, we just aren't checking it as often. And as a practicing internist, I know I would see it all the time, but because I didn't know really how to manage it or what to do about it, we often didn't do anything. And so patients' hematocrits would be 33, 34. I'd say, maybe send some iron studies and say, great, take some iron. But we really felt limited in what we could do. And I would frequently send patients to surgery with their crits are 33, 34. I was the one doing that.
So back to saying, more recently it has hit the radar in the United Kingdom because there's been some particular surveys that have been done, some particular population studies. And one of the striking features is how many students, in particular university students, are some of the cohorts they've looked at, and in particular female university students are now really quite markedly anemic.
Yeah.
In a way that may well be affecting their physical and their mental health.
Yeah.
So one of the things they flagged up is, perhaps, depression in that environment can be in some way linked to it. Have you seen much of this in the US at all?
So I think we have. I think we do see patients not feeling as well. We've actually had patients come to our clinic who were getting worked up for surgery, who we've discovered their anemia, have treated their anemia, they've canceled their surgery because they feel so much better. They thought, this is what's been wrong with me. I thought it was this, gallbladder. I thought it was this. I thought it was that. But it's actually, I feel so much better after getting my anemia treated, and I don't need that.
Has this hit your radar yet, Mike?
Not to the same extent, I have to say. I
think mine's been alerted to it because I've got daughters who are at university age, and one of our colleagues in London, Toby Richards, has been doing this work. So I heard him give a presentation. I thought, we should talk a little bit more about that. But I think your children are younger, so you probably haven't got to that discussion.
I've got a bit too much energy here, but a bit of anemia might be good.
Mike, is this familiar territory for you? Or?
Well, I've got daughters as well in that sort of age group, so it's coming to my attention. I think just the whole approach to what the optimal haemoglobin is in women needs to be looked at, because it's currently still only 12 with the WHO guidelines, and the question is, why should they be any different? Because we know now from big studies that if you actually look at TSAT, that a large proportion are iron deficient. If you give them iron, they go up to 13.
So that gender differential, which we all grew up, trained medical school, we were trained. It's one of the things you learn early on, that it's a different number, which physiologically doesn't make any sense. It's got a job to do in the body. It's moving stuff around. I'm assuming that the reason the number's different is because you sample a male population and they have a normal haemoglobin, that's the reference point. You sample a female population, and because anemia is much more common, probably because of menstruation and other issues, you come up with a number that is abnormal for the whole population, and you make that normal. I'm blithering a little bit there, Laurie, but is that the point? Is that because those two numbers they don't make physiological sense.
Yeah, you're right, and I think that is part of the problem. It's just that what we've been used to seeing. We brought up the idea that, well, in the studies that have been done, though, when we looked at their outcomes, and they use 36 for women and they use 39 for men, that is where it separates out. And you could see the curve. One of the studies we talked about this morning, that it is from 39 for women as well as when their perioperative morbidity goes up. Okay,
so that's a haemoglobin of 13 or 130 hematocrit.
Yeah.
So the inflection point, the differentiating point between doing well and less well is what we would regard as the normal value in men. Is that right?
That's right.
Yeah. Mike?
I'm just intrigued by the fact that women live longer.
Yep.
So maybe the normal is the female number, because one of the reasons men don't live as long is because of heart disease and vascular disease. I'm not sure we know where normal is.
You need to write that one down. I'm not sure we've got time for that at the moment. That's a very interesting point. Mike, any more on that?
Well, I think the other thing is, looking clinically, why this is important is that women are normally their ideal body weight is smaller, so the circulating red cell mass is less. And yet when you actually look at operations, blood loss is actually fairly consistent from operation to operation, whether you're a 90-kilo man or a 50-kilo woman. So what we've got is the fact that women often have a lower starting haemoglobin, a lower red cell volume, and are therefore much more likely to get the poor side effects from having high blood loss, even the same blood loss, the same as a man.
Right, so more at risk from that potential. Right.
Yeah, just to come back on piece, I think one of the interesting questions, which I think Mike has highlighted from his comments, is this differential between haemoglobin mass and haemoglobin concentration, and the dilution via plasma. And I think we're still at a very early stage of understanding whether mass or concentration is going to be more important in the long run.
So you could have a bigger tank with thinner blood in it, and therefore actually have more haemoglobin in your body. Isn't that part of what you found when you looked at the Sherpas at altitude, is that they've got a bigger tank, but it's more dilute blood?
There's an element of
way
that.
Off piece now, but
so yes, that is true, and it may be one of the benefits for them.
So back to the clinical issues we discussed today. The association, the data, when you look at big data sets and you say people who come in anaemia have worse outcomes, is completely compelling. So I think we can all agree that signal is very, very strong. The challenge we have then is converting that association into the causation link. Do you think we've reached a point where we can say with confidence that fixing the anemia makes a meaningful difference to outcome in the surgical patients?
I think that study still needs to be done. It's hard to get a randomized controlled trial for that, but yeah, it definitely needs to be done. But the information is compelling. I don't think it's absolute.
So we know in general health that being anemic is less good for you. We believe that fixing that anemia is good for you. But in the surgical setting, the signal that does seem to be very compelling and consistent is if you do fix the anemia preoperatively, you're much less likely to get a red blood cell transfusion, which I think is something we'd probably all like to avoid if we could do that safely. Is that right?
That's true. That's very true.
So, Mike, anything to add on that?
No, exactly right. We know that low starting haemoglobin is bad, and we know giving blood is bad. So the main intervention we need to concentrate on is getting our haemoglobin up preoperatively, and it seems whatever your haemoglobin is, you're better off with a higher haemoglobin, but we reach that ceiling point where actually a haemoglobin above 16, 17 then does do harm.
I think the interesting thing about it is that that's allowed many people to weigh in with their administrators, because there's an immediate business case for the assessment and intervention to reduce transfusion. So you've made the financial case, and I think that can then lead to knock-on or the opportunity to look at other areas where the business case is less clear, even when the clinical benefit may be equally good.
So the emotional case, I think, would be relatively easy to make directly with the patient. I think if anyone was given a choice between donor red cell transfusion, no transfusion, I think you'd struggle to find someone who'd prefer to have the transfusion. Agreed?
I agree, yeah.
Unless it means a delay of their surgery. Sometimes they'll opt for transfusion. Yeah.
Interesting.
Yeah.
Even with all
if you say, I'm sorry?
With all the potential associated risks, the speed of getting their surgery overwhelms that.
If we've just discovered someone with an anemia, their surgery's on Thursday, it's Monday, we say we're not going to be able to get your hematocrit up, they say I've taken off work, I've got an insurance approval, I'm all set to go for Thursday, then yes, many of them will go ahead with it. So that's why it's very important we get these patients early on, so we never have to provide them with that that choice.
Now, if you do get them early on, the big game changer in recent years is that you can give iron, as opposed to taking tablets, which those people who've tried it is often a very unpleasant experience and seems to go on for ages. You can now have the iron intravenously.
Correct, right.
And what's that like, and how long does it take? Is it a quick and easy thing?
Yeah, the onset is almost immediate. You really get a good effect within about a week, but peak effect is 2 weeks, generally for most preparations. So 2 weeks, and you really start to see a huge reticulocytosis. If you have strictly an iron deficiency anemia, those patients are really ready to go. It depends on how low they're starting and what their ferritin is, but really they're almost ready to go in about 2 to 3 weeks. But still, if they've taken off from work and they're ready to go and they want to have their surgery, they're expecting to have a surgery, they have family flying in to help them, it's a problem to delay and cancel their surgery. So we really do want to get them as early as possible so that we know about them.
So it's now a bigger education package then. So let's imagine I need my hip replacing. I probably should have on my own radar, as a member of the public, I should find out what my haemoglobin is, because if I'm anaemic, I can come and see someone like you, Laurie, and you can give me the treatment. Is a bottle of liquid, is it, that goes into my vein like a drug?
It is, yes.
And how long does it take to give me that?
So it's usually a 30-minute infusion, and then we watch them in the clinic about another 90 minutes, an hour to 90 minutes.
Is it very painful or no?
No. It's the IV start, the lidocaine with the IV start, and the infusion, and it's the time really of getting checked into the infusion center. So we generally tell patients to plan on 2.5 to 3 hours there, which is a big chunk of their day, but overall worth it. And
And the risk of the infusion per se, I mean, everything has a risk, isn't it?
Yeah. So there are the formulations that we use now with sugar preparations are much less risk than the old dextran formulations, the high molecular weight iron dextran. The risk is really almost a couple in a million of having an anaphylactic or some sort of allergic reaction with those preparations.
So the risk of a blood transfusion is much, much greater. The immediate risk and the risk of transmission of infections, etc., which we know blood's pretty safe now, but proportionally it's much riskier.
Right. Well, the risk of infection for HIV is 1 in a million, so it's around there, and hepatitis is 1 in 250,000, hep C. But other things like postoperative infections and longer lengths of stay, those are going to be much higher. Yeah.
And like the cost of because we think of the cost of a bag of blood, of donor blood, and in our country, in England, it's donated for free, for example, which it is in many countries. By the time it gets to be given at the bedside, the cost of transfusion per unit is much, much greater.
Correct, yes. I mean, just setting up the blood, the first unit is estimated to be between $300 and $500, plus all the administration costs can add another $500. It costs a little bit less to keep adding on the extra units of blood, but obviously it depends if you cross-match in 2 or 4 unit batches. And then you've still got the actual time of administration of the nurse on the floor, taking time to do the observations as well, and that's not really been calculated into many studies either. So
ballpark that's often bandied around is somewhere in the region of $1,000 per transfused unit of blood. Is that reasonable?
Yeah, depending whether it's Medicare or insured. Yeah.
So, and I'm going to make an assumption that the infusion of the iron is cheaper than that.
Yes.
Okay.
Yes.
So doing the business case is most readily on the I'm going to avoid those red blood cell transfusions. And that is going to, therefore, the cost equation is going to make sense. But also, if you have the lead time, the patient's going to have a better outcome in the short term, we think.
Absolutely.
Great stuff. Mm-hmm. So Mike, as we discussed in the session, there are large randomised controlled trials at phase 3 ongoing. Why, do you think?
So the PREVENT study is the striking one in the UK. I think it's about 50, 60 patients from completion. It's been a study that's been hard to recruit to, and I think our experience in Southampton is similar to many people's in that because of the availability of the intervention, so the sugar packaged iron, whilst the study's been going on, which is now I think 5-6 years, people have just moved on and started adopting it because of this issue that the business case it pays for itself in terms of reduced transfusions. So we're uncertain about the clinical benefit. Yeah. But the business case is so compelling that a lot of people have just jumped on the bandwagon anyway. Yeah,
I looked it up this morning. It was September 2012. It was registered on clinicaltrials.gov. It's 1,000 milligrams of the IV ferric carboxymaltose preparation, so the sugary iron thing. It was only scheduled to recruit 500 patients for the primary outcome variable, which was the transfusion requirements. And that's 6 years to get it done. And I think, as you said, what happened is the compelling evidence that we've just discussed overwhelmed the need to generate and complete the phase 3 trials.
It's also, we're one of the centres that are contributing to the study. It's a very hard, just the nature of the way the study's set up, it's hard to recruit to. It's actually easier to give people the drug clinically than it is to do it in the study.
Is there not an argue that because it's run away from itself, that the safety and efficacy data is there from real-life experience? Laurie, it seems as though you've been involved in treating thousands of patients, way bigger than any trial that will be done. So.
Right, that's right. And it's hard to get that design, and it's hard to ethically randomize them to no treatment. Yeah.
We do have some other safety and efficacy data from all the renal data as well, because obviously iron and EPO is given regularly for most patients on dialysis now. So I think we have another safety backup in the fact that there doesn't seem to be really any long-term effects that we can see at the moment in those patients, and they're getting repeated transfusions, not just, say, 3 before surgery.
I guess as one were to be a sceptic, though, we've got this concern that iron is potentially a promoter of infection, certainly in some circumstances. Quite a few people are giving iron relatively close to surgery, so I completely agree with the notion that you need 2 or 3 weeks. But actually, so we will give it closer to surgery because of the benefit that will accrue following surgery, so they're less likely to need a post-operative transfusion. And I think we should stay a little bit nervous. I mean, I'm a fan of the anaemia clinic, but we should stay a little bit nervous about those potential consequences.
But interestingly, Mike, when you look at the paper coming out in Anaesthesia and Analgesia last year, specifically looking at the NScript data and blood transfusion and infection, they got rid of this idea that it increased superficial surgical site infection, but deep surgical infections and septicemia were both very much increased in blood transfusion. And I think the signal from giving iron will be far less than the signal from giving blood.
And as far as I know, as IV iron that's thought to be a theoretical consideration. I don't think it's ever been proven to increase infection.
I'm with you. I mean, it's similar to steroids in ICU. Whenever we actually do the trials, there doesn't seem to be any increased risk of infection. But it's out there, I think.
So, declare a conflict here, because from reading about this and thinking about it for very personal family reasons, etc., I'm a convert, so I just have to say I don't have any other conflict apart from the fact that I think it's very compelling that IV iron is a good way to treat anemia with the knowledge we have available at the moment. But there is a large trial ongoing out of Australia, the ITAX trial that I found, again, I think it's from Paul Miles' group, and it's 1,000 patients. It started, I think, in December last year, and the primary outcome variable is this idea of what's commonly referred to as happy days. Mike, can you talk about that for a second, happy days, as an outcome variable?
I think it's a great outcome variable. It's similar to the notion in intensive care of ventilator-free days, so it's how many days within a defined period of time that you have out of hospital without being alive, principally, and sometimes with some added caveats around complications. But
at home is the important thing. It's at home and happy days. So this is a cardiac surgery trial. So they're trying to address primarily the outcome variable is that do you as a result of having your anemia corrected end up after your major surgery spending more days home and happy in the first 30 days after surgery?
Yep.
So that'll.
I think the other interesting thing from that study is the fact if you're giving intravenous iron preoperatively, it isn't just the preoperative effect that you get. You seem to get better erythropoiesis following postoperatively and a more rapid recovery. I think there's one study to show, reduction in length of stay. Is that right, Laurie?
Right, that's right. Okay.
And we've got the interesting crossover with the exercise data, because we certainly know with transfusion, if you transfuse someone, their physical fitness variables improve, and it looks like you get the same effect, not surprisingly, if you increase their haemoglobin by using intravenous iron.
Yeah, and we also talked about the data this morning from our institution that if we treated them with IV iron, the orthopedic patients were more likely to be discharged to home as opposed to rehab or a nursing facility.
That similar idea that the home and happy days is what we're aiming for.
Right.
So the last thing I'll just point you at, which is a project, and Toby Richards, who's a vascular surgeon from London, who's done a lot of work on anemia and anemia correction pre and perioperatively, but has swung a lot of his focuses around to anemia in young women. He's got a project running called Iron Woman. So exploiting the Iron Man concept, as far as I understand it, it's younger female athletes who are on that sort of penumbra of the high-level sporting world, who are not necessarily getting their haemoglobin levels checked on a regular basis, who transpire to be anemic and then can have their anemia corrected with intravenous iron, and their performance characteristics go up, if you see what I mean. Now, the plus side, and the reason I think he's doing that is not only can he help these young women's long-term health, etc., but it's a great way of drawing attention to the issue. You know, why women in particular? What is this treatment that can happen? And it's having quite an effect, an impact in London. There's a splash there because you can see that the idea of fit women who have this problem with the amount of blood in their body can be helped rapidly. Does that sound appealing?
It sounds wonderful, yes.
So please do look it up, Iron Woman, Toby Richards. Well, if you're listening, Toby, well done, mate. Right, anything else to add at this stage?
No, that's good. Thanks, Monty.
Laurie, anything else to add?
No,
Mike?
No, great discussion.
Great stuff. Well, thank you all very much indeed. Thank you for listening to Top Med Talk.
Thanks for downloading and listening to Top Med Talk. Don't forget to find us on social media. We're on Twitter, Facebook, Instagram, even got our own YouTube channel. Whichever your favourite social media feed is, we're bound to be there. Find us. Also, subscribe to this podcast so that you never miss an episode. And make sure you go to the Top Med Talk website, topmedtalk.com, and get on board with the email updates. Oh, whilst you're at it as well, I suggest you download our entire back catalogue. We're categorising it at the moment. We're having a little look through it. It may not always be in the form that you currently find it. So if you get your hard drive ready for a full-on download via the website perhaps, or perhaps through your podcatcher. Oh, and if you fancy meeting us, why not go to the website ebpom.org/meetings. Our next big event is EBPOM USA, the Dallas Masters Course, a perioperative care practicum. Have a look for details of that and some of the other meetings coming up across the next year. ebpom.org/meetings.